Well, interestingly, I was in the day when it wasn't offered at the time, right? So I did go, round by round. Every round was a different round, and it's unknown. And so, was it really torturous? Absolutely. Those 2-week waits were torturous. We are so super thrilled to have Nicole Logan here, who is the geneticist at Create Fertility. And in a couple of moments, Dr. Prati Sharma is going to join us, one of the fertility doctors at Create, because we're going to talk about something super crazy important, because just in the last couple of days, New York Times article came out talking about and claiming, that perhaps abnormal embryos through genetic testing can create babies. And we just want to shine the light on it, do a deep dive, because I think there's some misconceptions that we need to really be able to dispel here. And I believe Dr. Sharma is coming on right this moment. There she is. Hooray. Yay. We've got our team going. Hello.
Hi.
Hi. So thank you so much for taking time out of your really super busy day. But we know that this is a really super important conversation for those of us that are just joining right now. Again, this is Nicole Logan, the geneticist at the Create Fertility. And along with that is Dr. Prati Sharma, fertility REI doctor here with us. And we're going to address, can abnormal embryos become a real live baby? So we're going to start with straight to you, Dr. Sharma, because you emailed me and say, "Did you see this article?" And so I'm grateful for that. Let's talk about what was in that article and some myths that we need to dispel.
Well, I think, yes, this is a very important topic and quite fitting at the end of Canadian Infertility Awareness Week, where we're really trying to highlight the topic of infertility, what patients go through, and the available treatments that are out there for patients. And Pgta is one of the newest and most novel treatments, and something that patients really kind of hem and haw over quite a bit when they go into an IVF cycle, because one, it's expensive, but two, it's a relatively new technique. And all of the things that were stated in these articles are things that go through patients' minds. Do I need to do it? Do I not need to do it? Am I going to throw away good embryos? Am I going to put in a bad embryo? So all of these questions are looming. So it's a really important discussion. So when we talk about these articles, there were actually two of them. One was the actual published study that was in Human Reproduction by Barad et al. and Gleicher out of New York. And that study looked at a cohort of women who had only, quote, abnormal embryos left over from other centers. And they were sort of at the end of the road where they had nothing to transfer. And so they wanted to see if they could take these abnormal embryos and do a transfer in hopes that the embryo would self-correct, or that the PGS testing was not as accurate and could result in a baby. And so the idea was that they transferred these embryos from a variety of outside clinics to this center in New York, who definitely, with good counseling to the patients and, reviewing with them the risks, said, if this is your last shot, let's go ahead and try and see what happens. And what they found was that a certain number of those patients actually got pregnant with what ended up being normal babies. And so obviously we'll open up the discussion to the actual article and in layman's terms what this actually means. But the New York Times then took this article, rightfully so, and said, wow, this new technique that patients are sort of making decisions over, these tests show that an embryo is quote unquote normal, and then patients are having live births of perfectly normal babies. So is this technique really valid? Should patients be paying money for it? And are they discarding what could be normal embryos? Now, obviously, there's two sides to every story, and every story needs to be vetted appropriately. And that's why I brought this to you, Mary, suggesting that we talk about it in this forum with an expert on our side, like Nicole Logan, to really delve into the data and tell us how should we be interpreting this.
Absolutely. So why don't you, Nikki, address this with regards to, now, was it truly an abnormal embryo? Let's really talk about that piece.
Yeah, so this article, they had 141 embryos that they transferred, and they called all 141 of those abnormal. But if we really break down those embryos, 23 of them actually were mosaic embryos. So when I say mosaic, that means that some of the cells had abnormalities in them and some of the cells did not have abnormalities in them. They didn't share with us in terms of those mosaics, however, what the level of mosaicism was. So was it low level or high level mosaic? 9 of those embryos had no results at all. So they went for Pgta. There wasn't enough DNA collected at the biopsy, but those couples or individuals decided to transfer those embryos regardless. And 3 of the embryos were segmental aneuploidies. So there's new research out that says that embryos at day 5 or day 6, when a typical biopsy is taken of these embryos, if you find segmental changes, so that means that there's a small part of the chromosome that is deleted or duplicated, that if you find those changes, they may correct themselves quite quickly. And so if you find those changes, they may actually be mosaic changes, or if you decide to rebiopsy those embryos, we may find that they're actually normal embryos, or that those changes have already corrected themselves. So that's why it's interesting that they did those 3 segmental aneuploidies. Of those transfers, however, there were 141 embryos that were transferred in 57 transfer cycles. There were 8 live births in total. Of those 8 live births, 6 of them were mosaic embryos. And so that's what we've been, that's what I do at the clinic as a genetic counselor, is I talk to couples and individuals about transferring mosaic embryos and not fully aneuploidy. So fully aneuploidy is every cell examined has a chromosomal difference in it. So of the 8 live births, 6 of them were mosaic. 1 was one of those segmental aneuploidies that I just mentioned, and 1 was a whole chromosome aneuploidy. So it had actually a deletion on chromosome 18 and a duplication on chromosome 14. So that one would have been labeled as abnormal by most of these centers that did this genetic testing. So really, the sensational title of this article with IVF, IVF outcomes in of embryos with abnormal Pgta results, they've lumped all abnormals together, but really there are big differences between mosaic embryos, fully aneuploid embryos, and then this new information that we're learning about segmental aneuploidies coming out. And so we already knew, and this is a great article in reiterating that mosaic embryos have a good potential to be transferred and result in a live-born birth. And so that's where those abnormals are coming from this article.
So wording is key. And of course, as you said it, like they sensationalize. So it's part truths, and rightly so, because these are journalists that they don't have a science background. So they just say, oh, abnormal, right? And what we know that it's a very different situation when it's true aneuploidy, fully abnormal, to a mosaicism where it's like, well, there's some cells that are actually quite normal, right?
Right, exactly. And it is interesting in this article, there was one embryo that was declared fully aneuploid. And normally, at least at Create, we don't transfer fully aneuploid embryos. But that embryo resulted in a baby with a normal karyotype, so a normal healthy child. And I think how we can discuss and explain that embryo is that Pgta really is a screening tool and not a diagnostic tool. The accuracy of the test is not 100%. It's about 97%. So this one embryo that they have labeled as a whole chromosome aneuploidy probably falls into that error rate of Pgta, and that this embryo was likely actually a mosaic embryo as opposed to a fully aneuploid embryo.
I think I should also point out, Nikki, and it's interesting, there was a big discussion about this article and the original paper, as well as the New York Times article on a lot of the American and Canadian REI forums. And one of the things that was pointed out is that different labs will characterize embryos in different ways. And there are certain labs out there that will not report Mosaic still. So it's either abnormal or normal.
Wow.
So perhaps this one embryo was reported as abnormal, even though it was Mosaic. So probably follows along the same lines as to what you said, that it was probably Mosaic or that there was a small error in PGS. But there are labs that only report normal or abnormal. I think the data is evolving. There was another paper that was published last year by Richard Scott et al. From the RMA group. And it was a pretty landmark study in that it showed that when you use an effective platform for Pgta, like NGS, that if you deem an embryo abnormal, so fully abnormal, not Mosaic, the chances of it implanting and producing a live birth is essentially 0%. If you produce an embryo that's called normal, that's where you're in that 60 to 70% implantation rate. And mosaics are the gray area where we've all, as fertility doctors, seen live births with mosaic transfers. And so I think it's important, I come from the patient counseling side. I always have patients see you when they have mosaics, low-level mosaics or complex mosaics, to talk to you about the risks and the benefits of transfer. And that's what you're there for, because you're excellent at it. But when I counsel patients, I have to actually tell them what Pgta means and what your possible results could be. So I always really categorize the embryos into 3 different categories. Either I'll say it's completely normal, a mosaic, which is kind of 50-50, or completely abnormal. But that, as you said, Pgta is a screening test. It's not a 100%. But if you have a fully normal embryo, that's probably the best you could do to get your best possible embryo. If it's fully abnormal, you can, with 97% sensitivity, trust that that's not going to implant. And if it's a mosaic, we have to have a risk-benefit discussion. See what your palate is for risk of miscarriage, see what your palate is for invasive testing, and considering amnio and CBS. And I think good counseling here is key with the doctor and patient.
Yeah, I would agree. This article, so that was interesting that you said that some labs don't report out mosaics. I found another interesting part of this article is that, so that one embryo that was fully mosaic is the only embryo from that particular lab. So maybe that was the case there. But also these embryos were tested in 2015, 16, they're several years ago that these embryos were tested. And our technology is getting better all the time. So if some of these embryos may have been retested or rebiopsied, we may have gotten a different result today than we did, 5-6 years ago when these embryos were originally tested.
Yeah, that's such a great point, because of course, within 5 and 6 years, technology does increase and progress greatly and profoundly. So yeah, that's so super important. So for those of you that are joining, Dr. Sharma, as well as Nicole, we did another podcast with regards to prenatal testing. So similar kind of thing. So if you want to check that out, you can. That's episode number 15 on live fertility. And also, if you're kind of scratching your head about what the heck is a mosaic, what's in Pgta, we did a deep dive on that with Dr. Lorna Marshall from Pacific Northwest out of Seattle, the fertility clinic there. And number 16 was about normal embryo and can they guarantee a baby. And then number 17 was about should you actually transfer mosaic embryo. So we did deep dives on that. And so if we're going to go personally, because I always like to add in a personal spin, if you had fertility challenges right in this moment in your younger version of yourself, and you were presented with Pgta, would you actually do it knowing what you know? Start with Dr. Sharma.
Towards that. Yeah, I can definitely speak towards that. And I think the pendulum has swung quite a bit, because when this technique was new 10, 12 years ago, we were all very skeptical. And we said, only if you have tons of embryos and enough money to spare, you would do it. And then the pendulum swung the other way, which I think is kind of maybe where we're at, or where we have been over the last couple of years, where we said, oh, wow, this is the greatest technique in the world. It's improving implantation rates, lowering miscarriage rates, and everyone does PGT-A, even if you're using an egg donor who has young, healthy eggs.
Yes.
And now
right.
the research has all really kind of come out because there's so many studies being done, and we're sort of moving towards the middle, which is really the case that happens with most novel new techniques. And I think now we're really finding what the real indications for PGT-A are. And so when I talk about PGT-A to my patients, the patients that I really kind of counsel to move towards PGT-A are those who've had a history of an abnormal pregnancy, like a Down syndrome pregnancy, and they don't want to go through that again. And so their PGT-A makes sense because they can't even think about being pregnant until 10 weeks when they do the NIPT, because it's just going to be like being on pins and needles. If a patient has repetitive miscarriage without any other cause, then to go through another miscarriage can be grueling and torture and psychologically terrible for a patient. So repetitive miscarriage is also a reasonable indication for PGT-A to select the good embryo. If you're older age, over the age of 37 or 38, then your risk of chromosomal aneuploidy is increased. And so a lot of women don't want to put in an embryo that they have a risk of it being abnormal, that it could miscarry or be a Down syndrome later. And so they would rather use PGT-A as a selection tool to pick out the embryos that are normal to avoid that. Mm-hmm. Then the other category is younger patients. So younger patients are tricky because the majority of their embryos will be normal. But I think we all have seen it as fertility doctors, where you have a young, high responding patient that makes 10 embryos, they opt not to test them, and 5 transfers in, they're not pregnant yet. And they say, I wish I did PGT-A to find the one that worked. So there is an indication there for patients that don't want to do repetitive transfers with untested embryos and have very high ovarian reserve. And then there's the genetic indication. So if you carry a chromosomal abnormality or translocation, or something in your karyotype that will allow you to produce more abnormal embryos, then it's absolutely indicated to screen your embryos. Or for single gene disorders, the variant of PGT-A, which is PGT-M, to actually look for that disorder. So those are all the real calls. The question of doing it for male factor infertility, because men might have more abnormal sperm, or if you're using a gestational surrogate to allow her to get pregnant quicker, these are all soft call indications. And I think this is where really good counseling actually is important. And in all these cases, actually, I think it's important to counsel a patient, and you have to consider their financial status as well, because it's not a cheap type of treatment. You have to consider how many embryos they're going to get. If a patient is only going to make 1 or 2 embryos, I don't know if it's worth it. And back to your question, because I'm not avoiding it, if I was to do IVF, would I do PGT-A? I have to say I'm a woman of science, so I still really believe in the technique. So I would probably do it because I think the benefits outweigh the harms. That study I was talking about by Richard Scott showed that terectoderm biopsy is not at all damaging to embryos. We know that frozen embryo transfer in most scenarios is probably safer, not just for implantation, but also for ultimate pregnancy outcomes. So all of those things do favor PGT-A in my book.
Mm-hmm. Yeah, I would agree that, I think all patients should be offered the test and explained what it means, but maybe not. It's, some people may want to do it and some people may not want to do it. Especially like Dr. Sharma said, the patients with chromosomal abnormalities or other indications, we should, really encourage them to do this type of testing. But really, what I say to patients who are thinking about doing PGT-A is that, eventually, if you don't do PGT-A, eventually we are going to transfer all of those embryos and you will find an embryo that was diploid. But there's all of that. There's the cost of the transfers. There's the emotional concern, emotional labor that goes into, am I going to get pregnant? Was this transfer successful? Am I going to have a miscarriage? And then, maybe having a miscarriage. And that doesn't, miscarriages are common enough that, 10 to 12% of all pregnancies end up in a miscarriage. But if we can avoid that, why not offer that to the patients? And that's not to say that a euploid embryo or an embryo with the correct number of chromosomes will not result in a miscarriage, but there is definitely a less chance that will happen versus, an embryo that has chromosomal concerns. And also, just to add to what Dr. Sharma said about younger patients, patients are often surprised that a patient who is, an egg provider, or a patient who is, 25 years old, they still have a 70% chance of producing an embryo with the correct number of chromosomes. So that means there's a 30% chance that they're going to produce an embryo with an incorrect number of chromosomes. This isn't just for older women. All women have that risk. It just becomes much more significant as a woman gets older. And so I really do think that this is a test that should be offered to all patients. And some patients we might have to, suggest it a little bit stronger than other patients. But yes, this is a test that I would do. And again, because of the science and because I believe in the science of it, this is a test that I would do if I was in that situation.
So then, what about you, Mary?
Well, interestingly, I was in the day when it wasn't offered at the time, right? So I did go, round by round. Every round was a different round and it's unknown. And so was it really torturous? Absolutely. Those 2-week waits were torturous when it doesn't become, right? But so if I had to do it all again, perhaps I would actually do some freezing and testing batch, right? Like that. So then this is a question to you before we close off. I know that there's, you bank some embryos and then you test them all at once. What do you think of that? Because Dr. Lorna Brown Marshall made an interesting point that I had never heard of. So I just want to have your take before I add her piece in.
Yeah.
In terms of, sorry, just to be clear about, you got it. Okay.
Batching embryos, right?
Batching embryos and then taking the tissues, the biopsies, right?
And testing them later. I mean, regardless of when you do PGT-A testing, for the most part, it has to be a frozen embryo transfer. So regardless, the embryos will be frozen. The theory behind batching is that in women who have lower ovarian reserve or women who are not making as many embryos because they're older and have low reserve, knowing the age-related aneuploidy rate, just like Nicole said, for women under 35, they still have a 30% risk of making aneuploid embryos. As you get older, between 37 and 40, that's 50%. And over the age of 40, it's up to 75% of embryos will be abnormal. Well, if you have 2 embryos in an IVF cycle, what are the chances you're going to find a normal one with that one IVF cycle's batch? So we do a lot of batching at Create, and I think that's the standard where you do 2 or 3 IVF cycles. The embryos are going to be frozen anyway, and a sample's taken, stored on a slide, and then analyzed. There's no downside to doing that. And it allows 2 things. One is it allows you to have enough embryos to increase the odds of you having a normal embryo. And the second piece, which I think is really interesting and is really not a medical piece, I find, and I think a lot of REIs find, if a woman does 1 IVF cycle, has, let's say, 2 embryos at the age of 40, tests those embryos, and they're both abnormal, she's dejected. She's devastated. She might not come back for 3 months because she needs to kind of get over it. And so what we find is that the women who are batching, if that same woman did 3 IVF cycles, and after that 1 IVF cycle where she had only 2 embryos, she just went on and did another IVF, she knows there's an end point where she's going to make that 5 or 6, and she has a higher chance of getting to that normal embryo overall faster than if she just tested that 1 set of embryos, it was bad, and then she waited 3 months because she was upset about it and then came back. We find that when we keep patients going and they're continuing to make their embryos, they're more prone to get to the right one and get to the end of the story. And so I do sort of put in a plug for that because I think that patients do ultimately, I always tell my patients, I say, put in your hard work now, do your 3 IVFs and get your 6 embryos, and then get to that 1 in 6 where you have a normal one, and then you're at a 60% implantation rate, rather than doing it early, transferring a day 3, having a 10% chance, going away for 3 months, coming back. It prolongs everything.
That's a really, really great point. Your thoughts on that, Nikki?
There's the like Dr. Sharma said in the previous articles as well, there's very little risk of doing trifectoderm biopsy. But there is a risk of freezing, thawing, doing a biopsy then, and then freezing again. So I would say, do all the biopsies at the same time. and then freeze all the embryos. And then, you can get those results back because there's less risk of losing an embryo to a freeze thaw. That risk isn't very high, but it is much higher than the trophectoderm biopsy. The trophectoderm biopsy is going to it has a very, almost 0% chance of harming that embryo. Whereas the freeze thaw, it has a higher risk of harming that embryo. And also there's the cost benefit to it. So like Dr. Sharma said, if you batch embryos, if you were to do, have 2 embryos, 1 cycle and 2 the next cycle, and you did a Pgta after each cycle, that's more money. Whereas if you batch them, or if you do them, 8 embryos altogether, that's one cost, as opposed to doing it after each cycle and increasing the cost there. So yeah, I believe that it is a good thing to do the biopsies all at the same, right before freezing and testing all the biopsies at the same time.
I should also clarify something for patients who are watching. I think patients also worry that by just freezing the embryos in general, they're going to risk implantation for those embryos as opposed to doing a fresh transfer. And I think the 2 things that we're really sure of now, because laboratory techniques have really improved, is that 1, freezing and thawing blastocysts, so good quality embryos, has no decrement on implantation rate. In fact, a frozen embryo transfer may actually be better for outcome, both from early and late obstetrical outcomes. So when patients worry, oh my gosh, is my embryo going to survive the thaw? It's probably less than 1% of blastocysts that don't survive the thaw if you have a good cryo program going at your IVF center, where most reputable centers do. And as you said, the second is that trophectoderm biopsy and taking a sample of the embryo does not damage the embryo. So rest assured that by doing those processes, you'll be okay. But exactly what you said, the double freeze and thaw, so thawing your embryos later, there is data that can reduce the implantation rate. So you really don't want to do that if you don't have to.
Right. And I agree on all counts. And so going back to me, my story, and I did have a lower reserve, so having to do multiple transfers. So I would have batched, and I would have done it that way as well. But what I was going to add to it was Dr. Lorna Marshall. She said that sometimes we wait for, it doesn't impact the actual physical embryo, but perhaps the tissue that has been sampled, if it's been sitting too long before the testing, before the analysis, sometimes that can get compromised. And I had never thought of that before. Have you had any experience?
Comment on this? Isn't it frozen on a slide, so it's okay, or does the DNA degrade?
So at Create, as soon as we get that biopsy, we make DNA, and DNA is stable. So we don't keep the tissue until the testing. We extract the DNA from those 5, 6 cells that have been biopsied right away. And DNA is much more stable than tissue is. So that's not at least in our clinic, in our laboratory, that's what is done.
But that's highly informative. So if you are assessing out which fertility clinic to go to, that might be a good question, right? How do you store? Is it tissue? Is it DNA? And that's all great knowledge. Thank you for that. That just enlightened me.
I think the other thing to remember is we're very fortunate at Create, and other centers have the capability of doing in-house genetic counseling as well. I have to say, and I said this on the last podcast that we did together with Nicole. Nicole and our genetics team are a fabulous resource. So I think for patients out there who are choosing a fertility center, because I'd love to say it should always be Create and coming here, because I do think we're very good. But if it's not possible, you're from outside of Ontario or whatever it is, going to a clinic that has a reputable laboratory that's very good at doing the biopsies, because it is a technique that has to be perfected by the embryologist. So you don't want anyone willy-nilly sampling your embryos. So they're good at sampling the embryos. That uses a reliable lab, whether it's in-house or an outside lab, a lab that's been validated and has good results and recovery. And also having a genetics counselor that's accessible, because Mosaic embryos now, and with the level of detail we're getting from Pgta testing, these kinds of segmental and mosaic abnormalities are super common. And I will not have a patient go through a transfer if there's any question about the result without speaking to the genetics counselor, because they deserve to have all the information at hand before they make a choice. So I think we're very lucky to have Nicole on board to help us with those cases.
Wow, this was like juicy. Any last words? Because we all need to go back to work, but this was a really incredible episode. So thank you guys for jumping on live today.
Oh, no problem. I think, I've joined a few of those Facebook groups of parents and who are, considering transferring IVF. Just to kind of see what's going on. And this was an article that has been passed around a lot in those Facebook groups. And I don't think it was fully understood. So I thought this was a very important, live to do. And so thank you for including me.
Absolutely. Yeah. This is actually a crucial conversation. And so to give people informed choice and actually know the reality of the situation, not just a partial truth. Mm-hmm. Right. So there was just one abnormal, but that one abnormal is still likely mosaic. So that's the moral of the story, guys. So basically, at the end of the day, does an abnormal embryo create a healthy live baby? Likely not.